Hi, everyone. Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Daria, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or chat box for comments you may have throughout the webinar. Today's topic is Introduction to Shoulder Ultrasound, and our speaker is Dr. James Wilcox. Dr. James Wilcox is from Indianapolis, Indiana. He earned his medical doctorate from Indiana University in 2014 and completed his family medicine residency at IE Health Bowl Memorial Hospital in 2017. He then completed his sports medicine fellowship at Western Michigan University in 2018. He completed the RMSK certification for musculoskeletal ultrasound in 2021. He first served in the rural community of Austin, Indiana, practicing inpatient, outpatient primary care, emergency medicine, sports medicine, and substance use treatment. He recently relocated to Indianapolis in 2020, and now he's working on Eskenazi Health in outpatient primary health and sports medicine. In 2021, he accepted a grant-funded position at Indiana University School of Medicine, teaching point-of-care ultrasound and coordinating POCUS integration into four-year curriculum as the HRSC Prime POCUS Thread Director and Indiana University School of Medicine Associate POCUS Director. His clinical interests include sports medicine, point-of-care ultrasound, hepatitis treatment, and medical education. Please welcome our speaker today, Dr. James Wilcox.
Hello, I'm Dr. James Wilcox. I'm a family medicine and sports medicine doctor from the Department of Family Medicine at Indiana University School of Medicine. And today I have the privilege and pleasure to be able to discuss musculoskeletal ultrasound and specifically shoulder ultrasound with you. I am really excited to talk about this topic. As a sports medicine doctor, I see joint pain every single day in my clinic, but specifically trying to teach medical students and residents and faculty who are not sports medicine doctors how to do musculoskeletal ultrasound has been a bit of a challenge. I feel like a lot of us sports doctors and orthopedists and radiologists, when we try to teach musculoskeletal ultrasound, we tend to go into the weeds a little bit. We discuss a lot of anatomy, which is important, but we tend to talk about a lot of different things. And so I want to really focus our talk today looking very specifically at what we can do with point-of-care ultrasound with shoulder ultrasound. I'll give you a little bit of context. As point-of-care ultrasound, if we were doing a vascular study, we would really look very specifically, let's say for a DVT, and we would use our ultrasound looking at the vein. We would take a look at the ultrasound and we would maybe do a compression study. But that's it. We would just do our compression study just looking for a DVT. We have a very specific point of care ultrasound question. Now, when I'm asked to speak about musculoskeletal ultrasound, that's kind of like asking someone to talk about cardiovascular ultrasound. And there's a lot of different things you can do when looking at vessels that's not just looking for a DVT in the common femoral vein. You can do the compression study, but you can also do a B-mode study looking for calcifications. You can do a Doppler study looking at the waveforms of the arteries. And that you can do that for femoral arteries, femoral veins, carotid arteries and veins, many different vessels within the body. And so I really feel like when talking about musculoskeletal ultrasound, it's very important to dive down to very specific clinical questions. Very specific. What are we really looking for when we have someone who comes in with shoulder pain, for example? So let's dive in. Let's look very specifically. What are we going to do with our patient with shoulder pain? When someone comes into your office, your clinic, your emergency department, your urgent care with shoulder pain, what are you going to look for? Well, there's a lot of things that can be causing that shoulder pain. Biceps tendonitis, rotator cuff tendonitis. They could have a dislocated shoulder. With point of care ultrasound, what we want to try and do is focus things down. What's a very specific question that we can answer very rapidly using our ultrasound device? Maybe we're in a busy urgent care, or maybe we're in a busy clinic. We don't have time to do a complete shoulder ultrasound looking at all the different structures. But what we can do is a very focused examination, looking for very specific structures that will make a big difference in the treatment management for your patient. So today, what I want to focus on, what I really want to dive deep into so you have a good understanding of, are rotator cuff tears. It's a really common problem, a really common pathology in emergency departments, primary care, urgent care. And I really want to dial down into, does your patient have a rotator cuff tear or not? That's it. That's our very specific pointed point of care ultrasound question. Now we'll talk a little bit about full thickness tear versus partial thickness, tendinopathies, bursitis, but really our specific question we want to ask with our patient with shoulder pain, do they have a rotator cuff tear or not? So those are our learning objectives. We're going to talk about how to evaluate the shoulder for a common cause of shoulder pain with rotator cuff tears, and we'll talk about how to integrate our pathologic findings into our management plan. So taking a step back here, what's the difference between a musculoskeletal point of care ultrasound exam and our full radiological study? Well, when you're doing a full radiological study, you look at lots of different structures in the area of interest. But when you're doing POCUS, you look just at one very specific question, very specific examination for a very specific problem. For example, here, we're looking if there's a fracture. Is there a disruption in the cortex of the bone? So when we do musculoskeletal POCUS, we really need to start with our history and our physical exam. What are we looking for? Does our patient have pain with rotator cuff testing? Do they have weakness with rotator cuff testing? Okay, let's look for a rotator cuff tear. If they don't have signs and symptoms of a rotator cuff tear, then that's not what's going on with our patient. So our question is, does our patient have a rotator cuff tear? And again, point of care ultrasound is really great at targeted questions. For example, my patient has anterior shoulder pain. Do they have biceps tendonitis? Yes or no? But if your patient comes in saying, Doc, I've got pain in both of my legs from my hips all the way down to my toes, point of care ultrasound is not a useful modality in that case, because we'd have to cover a huge ground to try and figure out what's causing our patient's pain. We want to use our history, our physical exam to really target where do we think the patient's pain is coming from, and then ask a very specific question. Do they have a rotator cuff tear? Or something else, is it a knee effusion? Does my patient have an Achilles tendon rupture? So there are a lot of different indications that we can use musculoskeletal point of care ultrasound for. And a lot of these have been studied. Tendon and ligament problems like tendinopathy, rotator cuff tears, calcific tendinopathy. Joint problems like effusions, gout, dislocations. Using the ultrasound to guide your needle into a joint, especially if a joint is really thick and hard to get into by landmarks. Looking at fractures, looking at the muscles for hematomas or myositis ossificans, looking at nerves like snapping nerves, and many more things. There are many different clinical indications for musculoskeletal point of care ultrasound. Today I want to focus on rotator cuff tears. And as we talk about rotator cuff tears, I want to have a discussion about what healthy tendons are and what unhealthy tendons are. And you can use a lot of the things that we learn about today for rotator cuff tear in the shoulder as you continue to learn other point of care ultrasound applications, like maybe Achilles tendon tears or Achilles tendinopathy, maybe tendinopathy of the medial epicondyle for tennis elbow, or many different applications. As we begin, there's two very important terminology words that I want to make sure we cover. The first is anisotropy or anisotropy, depending on where you had your training at. What this concept is the ultrasound beams hit the tendon of interest and then they come back to the ultrasound. That tendon's going to be bright and white, hyperechoic. But if you tilt your probe, if you wag your probe to the side, some of those ultrasound beams, instead of coming back to the probe, will be bounced off. And instead of having a nice bright white tendon as we have in this top picture, now there's a dark hole that seems to have appeared in our tendon. This would be a rotator cuff tear if we didn't know that we had just wagged the probe or bent the probe a little bit, which caused that darkness to appear in the tendon. We can do this with a biceps tendon. This is the biceps tendon inside of the groove. As I wag the probe back and forth, there's the bright tendon, and then it disappears. So don't get confused when you're doing your point of care ultrasound evaluation, looking to see if a tendon is torn. Make sure you wag your probe back and forth, that it's not anisotropy that's causing it to look torn. Second thing we need to talk about is shadowing. This is air bubbles in a patient who had necrotizing fasciitis. These air bubbles cause shadowing going down below them. You can get shadowing from a lot of different things, from air. You can get it from calcium deposits. We get calcific tendinosis, myositis ossificans. A lot of things can cause these calcium deposits or air to appear in the muscle. But it's important to know that when something with air or bone or calcium is shadowing, we're not going to be able to make out anything behind that object. So we'll have to adjust the ultrasound probe, move it to the right or to the left in order to better visualize the structures that are below. When doing musculoskeletal ultrasound, a lot of our devices will have these focal zones. Make sure to adjust the focal zones to the depth of the structure that you're looking at. So here we're evaluating a couple of vessels. We want to adjust our focal zones so that they line up perfectly with the vessels of interest. And that focuses the highest resolution of your ultrasound on that structure. Also, we typically will use linear ultrasounds, like the ultrasound here in the middle that has a flat top. Those linear ultrasounds have a higher frequency and give us better resolution, so we can see those smaller tears, the smaller tendinopathy a lot better than if we were to use one of the curved probes that penetrate further. They have lower frequency, they go deeper into the patient, but the resolution is not as good. Sometimes we do use curvilinear probes, like the abdominal probe or a phased array probe that might be used for cardiac or aorta scanning, so that we can see deep, maybe in the posterior shoulder, to see deep into the shoulder joint, or we might use it for a hip evaluation. Typically, we're using the linear high frequency ultrasound probes. A brief literature review. There's a meta-analysis done a couple of years ago looking at ultrasound diagnosis for rotator cuff tears. They looked at over 500 different rotator cuff tears and compared what the ultrasound findings were with MRI or arthroscopy. Actually found pretty good sensitivity and specificity. So the ultrasound was almost as sensitive as an MRI or arthroscopy at picking up these rotator cuff tears. So I think that's really good evidence to show that, especially in the hands of someone who has had experience looking at rotator cuff tears, your sensitivity for picking up rotator cuff tears is going to be very close to that of an MRI. Some other applications, AC joint arthropathy or osteoarthritis of the AC joint, very high sensitivity and specificity. Even looking at labral tears on the shoulder, sensitivity is not as good. We can't see the entire labrum, but specificity is pretty high. If you see a labral tear, chances are it is a labral tear that you're seeing on the ultrasound. And also looking at these ultrasound guided joint injections, you can see for almost all of these joint injections evaluated in this systematic review in 2015, the accuracy using ultrasound is much higher. It's about the same for bursa injections, but looking at biceps tendon and glenohumeral joint, AC joint, accuracy is much higher because you can visualize the structure you're looking at to be able to guide your intervention to that structure. So how are we going to evaluate a tendon? Well, when looking at a tendon, first you want to look in long axis and in short axis. So this is our biceps tendon. We have it in long axis here. You can see like a cable structure of the tendon. And what's important is that the structure has these linear structures moving through the tendon, and there are no large gaps within the tendon. We then want to look at that same tendon in short axis. So this is the biceps tendon inside of the bicipital groove in the anterior shoulder. And we're looking at it in short axis. Again, making sure we're not missing anything from long axis. And again, I want to talk about anisotropy and show these pictures because it's very important, especially as we go into talking about what a rotator cuff tear looks like on ultrasound. It looks very much like a chunk taken out of the rotator cuff tendon. And if you have the ultrasound probe off slightly, it's going to look like there's a chunk missing from your rotator cuff tendon. So make sure whenever you're evaluating tendons that you're always bending and wagging and moving the probe, rotating the probe to make sure, is that dark spot you see truly a disruption in the tendon fibers? Or is it just anisotropy, that you're not seeing the tendon in a completely perpendicular manner? This is a cartoon picture of the anatomy of the rotator cuff from Ortho Info, the American Academy of Orthopedic Surgeons. I wanted to show this picture because it has a really great cartoon about what we're going to see on the ultrasound. So usually we'll either start at the AC joint up at the clavicle. You can palpate this pretty easily at the top of the shoulder. And you have your ultrasound probe in transverse, and then you'll slide down to be able to visualize the rotator cuff, or you can start in the bicipital groove. I like to start at the biceps because I can palpate with my finger and be able to see the biceps tendon, and that'll be home base. Medially from the biceps is going to be the subscapularis. Laterally back behind the humerus is going to be the infraspinatus, and superior to the biceps tendon is going to be the supraspinatus. So this is what a normal supraspinatus rotator cuff tendon looks like on ultrasound. There's several different layers. One of the best recommendations for looking for rotator cuff tears, especially full thickness tears, is looking at the layers. So looking at the layers of this tendon, first we have the skin and the soft tissue at the top. And then diving down deep, we're looking at the deltoid muscle. Below the deltoid muscle is going to be our supraspinatus tendon. Below that supraspinatus tendon is the cortex, the bone of the humerus. This is the white. And on top of that is the cartilage structure of the humerus as well. That's the dark anechoic area. So when looking at our rotator cuff tendon, make sure you can count each layer. You have the skin and soft tissue, the deltoid, the supraspinatus, rotator cuff tendon, and then the humerus. First, we'll take the shoulder, have her position the shoulder with her hand palm up, elbow back, so that we can identify the rotator cuff on the anterior side of the shoulder. You can do this by palpating the clavicle out to the AC joint, then dropping down
defines the biceps tendon, which is going to be where we start the evaluation for the rotator cuff, or you can palpate for the biceps tendon in the groove first and place your ultrasound probe there. So we'll start with the marker dot pointed towards her right. We'll palpate for the AC joint. Place the probe right on the AC joint. And you should see the collarbone and the acromion as they meet. It'll be kind of a cartoon bird appearance. You can look all the way to the lateral side of the acromion, or you can follow the clavicle or medial. We start at the junction of the AC joint, and then we'll fall down inferiorly to see the humerus below. The biceps tendon will start initially inside of this groove. The biceps tendon can show anisotropy, so you can wag the probe, and the tendon will become darker and brighter. The first rotator cuff tendon we'll evaluate is the subscapularis. We'll have our patient externally rotate their hand, and the subscapularis comes right into view. We'll adjust the depth. You want to look at the subscapularis tendon completely from its most superior to inferior portions, looking for any tears or breaks. If you find something that looks like it might be a tear or a break, you want to, of course, wag the probe to see if that truly is a tear or if it's just anisotropy. Once you've evaluated the tendon in long axis, you want to rotate your probe 90 degrees and evaluate the tendon in short axis. Again, looking for any tears or breaks in the normal tendon structure. Next, we'll go back to the home base, biceps tendon. We'll have our patient put her hand back on her leg. Find that biceps tendon in the groove, and we'll look for the infraspinatus. We'll find this structure by going laterally around the shoulder and also just a little bit superior to find the infraspinatus tendon right here. Again, we'll look superiorly and inferiorly through the infraspinatus tendon, looking for any tears or breaks in the tendon. And again, we'll look 90 degrees and look at the infraspinatus tendon in short axis. Again, looking for any tears or breaks in the tendon. Lastly, we'll have her put her hand on the back side of her hip. And it's important to make sure the elbow is tucked in. And then we'll look on her shoulder, again, very similar position, the anterior position, the marker dot pointed towards the head. I like to start at the acromion. It's an easily identifiable structure. Then drop down. Be able to visualize the supraspinatus tendon. This is the most commonly injured rotator cuff tendon. So you want to make sure to evaluate the tendon along the full thickness of the tendon, both in long axis and in short axis. Again, looking for any signs of tears, breaks, or pathology. Wagging the probe back and forth as you go to make sure none of those small inconsistencies are actual tears.
So now that you know how to evaluate the tendon and what normal looks like, let's go over some pathology of the rotator cuff tendon. So here's our normal picture again with the rotator cuff in the middle. You have our cortex of the humerus, deltoid and soft tissue over top. When we look at pathology of the rotator cuff tendon, there are many things that it could be. You could get calcium deposits within the tendon. This is calcific tendinosis. You can get a bursa, a bursitis. Typically, if there's an injury, inflammation, you get swelling within the bursa, you get bursitis. You can get infections that can cause bursitis. You could have a full thickness tear, you say here. You have a partial thickness tear, you see only a chunk missing out. You can also get hyperemia, which is if you turn color Doppler on, you can see these small the inflammation around the tendon, which is caused by tendonitis or inflammation of the tendon. You can also sometimes see neovascularization. So some of these might just be inflammation. Some might actually be new blood vessels. We'll commonly see that in Achilles tendinopathy, plantar fasciitis, when there's been chronic tendinopathy there. This is looking at the Achilles tendon as another example. You can use what we're talking about today with tendinitis, tendinopathies, rotator cuff tears for tendons all over the body. So it's a similar example. Looking at the Achilles tendon, this is the calcaneus, there's the skin and soft tissue over top, and this is the Achilles tendon. It's a strong fibrillar structure, looks kind of like a cable. And you can see here that tendon's been ruptured. So instead of having a nice, strong fibrillar structure like we have on the normal side, there are two ends of this Achilles tendon that have been ruptured. So this is going to be a complete tendon rupture. This is pathology for the shoulder. Looking here on the left, we have the cortex of our bone. One giveaway that there's pathology: if you see irregularities, the cortex of the bone right next to the rotator cuff, chances are there's probably an injury to the rotator cuff there. And we can see an anechoic bite missing out of the rotator cuff tendon here. We also see some bursitis. So this is the bursa and then the deltoid on over top of it. So this patient has a partial tendon tear. You can also see that on this video here, looking in the long axis, a piece missing out of the tendon here. And looking at that same patient in short axis, there's a piece missing out of the tendon. So you notice though, the tendon itself continues on in short axis over top of that small hole that's missing. So this hole, this tendon rupture, doesn't go through the full thickness. It's only in the bone side. We call that the cortical side. So this would be a partial tendon rupture. Again, here's another image in long axis and in short axis, the partial tendon rupture. So we see the break in the cortex of the bone, which is really common with these partial ruptures. And this is in short axis as well. What we see on this slide is a full thickness tendon rupture, contrasting the partial thickness. Up above, you can see, again, the cortex of the bone, some mild irregularity. We see the rotator cuff tendon, but there's this large chunk missing. We see the deltoid over top and the soft tissue. This large chunk goes all the way from the bone, all the way up to the white hyperechoic plane between the deltoid and the supraspinatus. I think you can make it out a little bit better in short axis, which is why I always recommend looking in short axis. Here's the cortex of the bone. Here's the deltoid over top. You can see this dark anechoic hole goes all the way from the cortex of the bone, all the way straight up to the white hyperechoic plane between the deltoid and the supraspinatus. And here's that defect marked out with calipers. So this would be an example of a full thickness tear. It goes completely from the bone up to the deltoid. So we have the full thickness of that rotator cuff tendon has a tear. There are a few additional signs that you might see when evaluating a shoulder for rotator cuff tear. First, you might see something called the double contour sign. You see the cortex of the bone here and a little white line above it, and a black line separating the two. This is the cortex of the bone. This black line is the cartilage. And that white line is actually acoustic enhancement. When we're comparing this rotator cuff tear, it actually enhances the visualization of the cartilage. So we get a white line, a black line, another white line. That's the double contour sign. You could also see bursitis. So that's swelling or inflammation of the bursa. You can see biceps tendon fluid. So this is looking at the biceps inside of the bicipital groove. And right here, we can see some dark anechoic fluid that surrounds the biceps tendon. If you see that, it could be a sign of biceps tendonitis. It might also be a sign that there's a rotator cuff tear or labral pathology, some kind of injury deep inside of the shoulder joint. Another sign is the geyser sign. So again, looking at that AC joint that we started with before, the clavicle and the acromion, if there's dark anechoic fluid kind of gushing out of the AC joint, it could be specific to the AC joint. It might be AC joint arthritis, but it also might be a sign that there's a rotator cuff tear or labral pathology or something deeper inside of the shoulder. So what do we do about these rotator cuff tears? Well, we use our ultrasound to help us decide, does this patient have a partial thickness, or is there tendinopathy, or maybe they have a full thickness tear? And often with the partial thickness tears, you'll see a patient has mostly normal strength. It might be limited a little bit because of pain, but certainly in a full thickness tear, they're going to have reduced strength. So you can correlate that with your physical exam when you're doing the empty can test or when you're assessing their internal or external rotation strength. Is their strength reduced compared to the normal side? If the strength is reduced and you see a full thickness tear on your ultrasound, likely that's what is causing the problem. But if their strength is mostly the same and you see a partial tendon rupture or tendinopathy, often we'll treat these patients with a course of physical therapy. The therapist will help them to rehab their shoulder as the tendon heals. You can use NSAIDs or Tylenol to help them with pain relief. Some clinicians will offer a subacromial bursa injection to help them with their pain temporarily as they work with the rehab specialist to improve the healing of the rotator cuff. Contrast, though, with a full thickness tear, if your patient truly has a full thickness tear, it'd be important to go ahead and get them an MRI to be able to measure the size of that tear and then refer to your surgical colleague. Full thickness tears, especially if there's weakness involved, tend not to heal on their own. As they heal, they scar down in that weaker position. And so this is the big divider and why we want to do point of care ultrasound for a rotator cuff tear. It's not just to help you with the diagnosis, but it's to help you with the management plan. If this patient only has a partial tear or has tendinopathy, you can go ahead and treat them by referring them to your rehab specialist. But if they do have a full thickness tear and you confirm that with your point of care ultrasound evaluation, you don't need to waste their time going to see a physical therapist or a trial of NSAIDs. You really want to go ahead and get them the MRI and send them to the orthopedic surgeon. Then they can evaluate, is that full thickness tear really small? Is it something that they think maybe a trial of therapy will be beneficial for? Or more likely, if it's a larger rotator cuff tear that you can see with your ultrasound, they're probably going to be a surgical candidate. All right, let's test your knowledge. We have a 62-year-old who comes into your urgent care with pain after starting a lawnmower. They have pain anteriorly and lateral on the shoulder, and this pain is worse when they're lifting it above their head. You do an exam, and they do have some weakness on the empty can test, but it's mostly normal. So you take out your ultrasound. We want to find out, does this patient have a rotator cuff tear? As you're evaluating their rotator cuff, you finally come to the supraspinatus, and this is what you see. Here's the long axis view of the supraspinatus tendon. And I'll show that one more time. And then here's the short axis view of that supraspinatus tendon. And I'll show that one more time. So, what do you think is going on with this patient? Do they have a rotator cuff tear? Is it full thickness or partial thickness? Do they have tendinopathy, bursitis? What are you going to do for this patient? Well, if you thought that they had a partial rotator cuff tear, you're correct. You can see on the long axis view, there's a disruption in the cortex of the bone. That should key you into that there might be something going on in the rotator cuff tendon. And we can see there's a little chunk missing out of this rotator cuff tendon. It's not large, and it definitely doesn't go through the full thickness. There's a small bite missing out of the rotator cuff tendon. Then when we look on short axis, again, we see that little cortical disruption and a bite missing out of the rotator cuff tendon. Not large, it's very small, and it definitely doesn't go through the full thickness of the tendon. So we can diagnose this patient with a partial tendon tear, and they should do really well working with a physical therapist to rehab their shoulder. If you would like, if you get experience doing rotator cuff evaluations, you can use your ultrasound to guide a needle to the subacromial bursa to do an injection. That's what we do on this slide. We have our needle, and we guide it underneath the deltoid. The first injection of a little bit of the medicine actually went into the deltoid, and the second injection of medicine now goes down into the subacromial bursa. It goes down the shoulder, and it also goes deep inside the shoulder. And that subacromial bursa injection, we can be confident that it's going to bathe the entire tendon in the lidocaine and the corticosteroid. There might be other injections that can be used for rotator cuff tendons outside of corticosteroid injections. There's dextrose prolotherapy or platelet-rich plasma or even stem cell therapy and other injectable medications that are being researched currently. But using an ultrasound, you're able to guide your needle much more effectively. And as I'm doing this injection this first time, I notice, oh, I'm in the deltoid. So I need to advance my needle a little further to get it into the subacromial space so we can delineate that supraspinatus tendon and the deltoid. I would not have known that if I was just doing a palpation-guided injection. And thankfully, getting corticosteroid or lidocaine inside of the deltoid isn't going to cause much damage to the deltoid. We do it often when we do intramuscular steroid injections for if someone has poison ivy perhaps, or if they have an asthma exacerbation. But getting a corticosteroid injection inside of a rotator cuff tendon can cause a little bit more problems. It might cause fraying of the tendon or degeneration of the tendon in a long term. So we try not to get the corticosteroid inside the tendon when we're doing our subacromial bursa injections. Thank you very much for your attention. I hope this was a helpful presentation looking at rotator cuff tendons, very specifically for your shoulder point of care ultrasound evaluation. I hope you're able to use this learning webinar as a way to start your journey with point of care ultrasound and hopefully pick up a few tips and tricks if you've already done several musculoskeletal ultrasound evaluations that can help you dive a little deeper into rotator cuff pathologies in the shoulder. If you have any questions, I'm happy to answer. And again, my name is James Wilcox. Thank you so much for watching this webinar. Here's my email address. Feel free to reach out to me and contact me if you have any other questions about rotator cuff pathology or any other musculoskeletal ultrasound questions.
Thank you so much.
You have a wonderful day.
Dr. Wilcox is here with us. So thank you so much again for joining us today, Dr. Wilcox. This was an amazing presentation. We saw a lot of feedback in the comments. So don't go anywhere. We still have Q&A part as well as a couple of questions that we want to launch and test your knowledge. So you'll see on the screen our first question that Dr. Wilcox prepared for you. And if you want to take a little bit of time to read through and test your knowledge, I'll give maybe a minute for everyone to see. Let us know if you're not able to see it on the screen. But I see people already responding. So we have currently 155 people watching us. So we'll give another minute for everyone to respond. And if you have any questions for Dr. Wilcox, please feel free to submit to Q&A box and we'll address them once we go through these questions. All right, we have 40% people who participated, so maybe another 10 seconds. So okay, I'm going to go ahead and poll and share the results. Dr. Wilcox, do you want to comment on any of those responses?
Yeah, so for whatever reason, I'm not seeing the responses on my end, but that's okay. Did most people get that it goes, I think it was question.
The question was, how do you tell if I'm sorry.
I believe it was question 4. So it's
Yes.
or the answer 4. So the full thickness tear goes from the cortex to the bone for supraspinatus anyway, goes from the cortex to the bone all the way to the deltoid. If it goes all the way up to the skin, that's probably too far. And so that's one of the answer choices. But remember, it's when you're doing an evaluation for the full thickness tear, it's important to look at each layer on your rotator cuff image. So you have the layer of the skin at the top, and then you'll have the deltoid often there next, and then the rotator cuff tendon, and then the humerus below. So make sure each layer, and if you're missing a layer in the rotator cuff, then that'll be your full thickness tear.
And we have 59% of people responded correctly. So
great job.
Great job. Yes. Moving on to question number 2. When do you refer a patient to your surgical colleague? So there is a couple of answers on your screen. So pick one. This one goes fast. Okay, we have about 40% of people who are still online answered, so I will give another 30 seconds. Okay. 10 more seconds for everyone to submit your answers. Here we go. All right. We had 85% answered a full thickness rotator cuff tear with weakness on exam.
Great. Means you all were listening. Yeah,
Yes,
so full thickness tear, that's going to be, like we just said, from the cortex of the bone all the way up through the rotator cuff tendon. But also you want to have some weakness on exam. Sometimes those full thickness tears are actually really small and tiny. They might be at the very edge of the rotator cuff tendon, and maybe they're not that clinically significant. Your surgical colleague probably won't perform surgery unless their rotator cuff tear is clinically significant. So as you're looking at it, those are the two pieces you want to make sure and put together. On your physical exam, do they have weakness with that rotator cuff? And then on your ultrasound exam, do they have a large full thickness defect in the tendon? So great job, everyone.
and the last question, how sensitive is ultrasound at detecting a rotator cuff tear? We have 70%, 75%, 95%, 50%, or 5%. Okay. Half of you are submitting answers, so I'll give another 20 seconds. Okay. And here are the results. We had 20% people answer 75% sensitive, 80% answered 95% sensitive, and that's between those two. So which one it is, Dr. Wilcox?
Great job again. So you all were listening.
Okay.
Yeah, so ultrasound in the hands of someone who's experienced is going to be 95% sensitive at picking up rotator cuff tears, which is actually pretty good for a handheld device that you can have at the patient's bedside, and doesn't require a special magnet room or transporting the patient. That being said, as some of you might be just starting your journey learning musculoskeletal ultrasound, or even just starting with point of care ultrasound, your sensitivity won't be as high until you've had a lot of practice. So the more you practice, the more you look at rotator cuff tendons, the better you get at it, and the higher your sensitivity, the better your competency is going to be when looking at rotator cuff tendons.
Perfect. Thank you so much for taking the time to go over these questions. While we're going to be proceeding to Q&A, I'm going to launch another question for you guys to see if you can help us understand if this session was helpful for you. So I'm just going to let it run in the background if you want to take some time, but we can move to the Q&A box, and we have quite some questions for you, Dr. Wilcox. So let's start with the first one. Hi, doctor. Thanks for the presentation. Please, is there any particular lengths of the linear probe to choose?
That's a great question. So there's several different kinds of linear probes that are available, and it just kind of depends on what you're looking for with musculoskeletal ultrasound. My ultrasound probe that I tend to use the most is 10 to 5 megahertz linear ultrasound. And so it gives me kind of a good general view for a lot of different structures. If you want very specific, you can go at a higher frequency, and there's, so I don't know what the specific term is. We call it a hockey stick probe, but there are more higher frequency linear probes that you can get that'll give you really good resolution, but you trade in the depth. And so when we're looking Some shoulders, even just looking at the rotator cuff, some of my weightlifters who have really large deltoids, I've had to pull out actually a different ultrasound probe, a curvilinear probe, to be able to get the depth to be able to see the rotator cuff. So I would recommend, if you're going to be looking at rotator cuff tendons, have something that's a good kind of general mid-range linear ultrasound probe, and then kind of based on that, if you want to make adjustments.
Perfect, thank you. Next question is, thanks for a nice presentation. What is the average diameter measurements for normal SASD and post-GH joint?
Yeah, great question. I think that's going to be subacromial subdeltoid bursa and the glenohumeral joint. I think that's probably what they're asking about. So there really shouldn't be hardly any fluid at all in the subacromial subdeltoid bursa. So if there's some in there, that's going to be pathologic. Now it can be, there's a lot of things that can cause fluid to accumulate in a bursa. It could be inflammation of that bursa itself, like a bursitis, but there can all be other things. There can be gout or rheumatoid arthritis, or rotator cuff tears we talked about can cause fluid to accumulate in the bursa. So probably anything larger than 1 millimeter or 2 is going to be abnormal for your subacromial subdeltoid bursa. Glenohumeral joint, you can have a little bit of fluid in there and it can be normal, but anything larger than probably 6 or 7 millimeters is going to be an effusion. So yeah, that's probably about roughly what you would like to look for as far as anything abnormally large there for the bursa or for the shoulder joint.
Thank you. Does any amount of fluid around biceps tendon considered to be abnormal?
Yeah, so normally there shouldn't be any fluid, any anechoic fluid around the biceps tendon. It can be a sign of biceps tendonitis. So I really like doing something called sonopalpation, where you use the ultrasound and you kind of push in on the structure you're looking at to tell you, is that the structure that's tender or not? And if they have fluid around the biceps tendon and they're tender on the biceps tendon, and you can correlate that with your physical exam, then it's probably biceps tendonitis. But if they have fluid around the biceps tendon, but it's not tender, your physical exam findings for biceps tendonitis are negative, maybe that fluid's coming from something else. It could be coming from a torn rotator cuff tendon. It could be coming from a labral tear. Could be coming from glenohumeral joint arthritis. So anything that can cause fluid to accumulate in the bursa.
Thank you. Do you think there is any use in assessing fat infiltration in the rotator cuff muscles themselves?
Absolutely. So that's kind of a more advanced question that your surgical colleagues will know how to evaluate. We typically have used MRI as a way to assess for fatty infiltration, just because it's very quick on the reading end to be able to quickly look at the supraspinatus versus the infraspinatus. We tend to use teres minor as like our control because that doesn't rupture as often to look for fatty infiltration. But ultrasound can also show fatty infiltration of the rotator cuff. You would have to look at the posterior shoulder where those rotator cuff muscles lie. Subscapularis is a little bit harder to see because that's going to be deep and underneath the scapula. So it's kind of hard to assess fatty infiltration for that rotator cuff muscle. But the others, being on posterior to the scapula, you can actually either look at the echogenicity, whether it's hyperechoic, and compare the muscles within the supraspinatus, infraspinatus, teres minor. If you need to, if all of them are terrible, you can compare it from one side to the other, the patient's normal shoulder.
Okay, thank you. Another question is, great lecture. What is the difference ultrasonically between tendinitis and partial thickness tear?
Great question. So tendinitis and so a partial thickness tear, you're going to see on the ultrasound. You'll see a big hole or a disruption of the tendon, whereas tendinitis is going to be more inflammation of the tendon. So you'll see swelling around the tendon. You might see the edema that we talked about on the Doppler. You might see neovascularization in tendinitis or tendinopathy. You can get a lot of crossover. So we will sometimes see both. We'll see tendinitis, inflammation, and partial tendon tears together. So that can happen. And so you might see kind of a mixture of both as well.
Thank you. What is the sonographic criteria for SASD bursitis?
Yeah, I think we answered this a little earlier, but there really shouldn't be any fluid hardly at all. If you're measuring at least a millimeter or two or more, then there's an abnormal amount of fluid inside the bursa.
Can you please help to explain tricks to understand GH adhesion versus normal GH joint?
Okay. That's going beyond rotator cuff, which is totally fine.
Bonus content.
So once you've managed your rotator cuff tendinitis versus partial tear versus full thickness tear, once you've mastered that, there are other things that you can look for damage to the shoulder. And we sports medicine and radiologists and orthopedists, we like to nerd out about all the different kinds of pathology that you can have in the shoulder. But I think looking at adhesive capsulitis, and then looking at glenohumeral joint arthritis, you can see differences. So glenohumeral joint arthritis, you'll see disruption of the normal black cartilage in the back of the humerus. And so that'll be your sign that'll cue you in that there is arthritis in the glenohumeral joint. And it really does pop out on an ultrasound. I've been surprised at how I'm able to pick it up a lot easier on ultrasound than X-ray. And then, so you can see glenohumeral joint arthritis really well. And then for adhesive capsulitis, that's looking more at the capsule. And there's some glenohumeral ligament and a few other structures that you can measure their thickness to determine whether it's a normal thickness or if it's swollen and thick, which is with adhesive capsulitis, you'll have a thickened capsule. There's a bunch of numbers out there as far as like range of normal and that kind of thing. But the easiest way when you're doing point of care ultrasound is just compare it to the other shoulder. If the other shoulder is moving normally, measure the thickness of the glenohumeral ligament of the frozen shoulder compared to the normal shoulder. And if it's thick, that's another clue, another piece to understanding that, yes, this diagnosis is adhesive capsulitis.
Thank you so much, Dr. Wilcox. We are unfortunately at time, so I'll email some of the additional questions. There's a couple of left, and then we'll email back the responses to you guys. But thank you so much, Dr. Wilcox, for giving us this excellent presentation. And thank you everyone who joined us today. This webinar was recorded, so it will be published next week for you to review, and you'll receive a link with the recording as well via email. Again, thank you so much. We hope to see you in our next webinar in September. And thank you, Dr. Wilcox, again.
Thank you so much for having me.
Yes, have a good one. Thank you, everyone.